Welcome to Adapt English, and today I'm going to talk about some key procedures that the NCLEX examiners like to ask you about. You want to know what need to be done before the procedure, counseling, what you need to know post-op, how to manage these patients, and what you need to look for when there's complication. So let's get into it. So for the liver, first of all, let's see what the liver is. So if this is your abdominal wall and the diaphragm is here, your liver sits here like that. And then he has what we call hepatic artery supplying blood to the kidney, to the liver. We have the portal vein, which is a big vein, retaining all the blood from the GI tract. So this is portal vein to the liver. These veins join together to form inferior vena cava, together with the other veins to return blood to the heart. So as you can see, the liver is a vascular organ. What does that mean? That means tons of blood everywhere going to the liver. So anything you do to the liver, basically you're putting a needle through a structure that contains a lot of blood vessels, and they can bleed. Liver can bleed if you puncture it. And therefore, based on that pathophysiology, what do you think? Well, if a patient is going to have a liver biopsy, what should we want to prevent? Well, we want to prevent bleeding. So we want to avoid anything that will cause the liver to bleed. Usually, you want them to avoid taking NSAIDs. NSAID cause bleeding. So they need to stop NSAID at least a few days. Like aspirin, if they're on aspirin, well, 7 days, they should stop taking aspirin for 7 days. They should avoid taking any Coumadin. So they need to stop this at least 5 days. If they take any anticoagulation, so any anticoagulation, you know them, Lovenols, all the agatobans and the new factor 10 inhibitors, the indirect, and direct factor 10 inhibitors, they need to hold all of them. They all have their half-life. Some of them, they got to stop it for 2 days, like a PCBAM, which is a factor 10 inhibitor. They need to stop 2 days before the procedure. So you got to give them precautions to avoid all of them. Of course, what would you want to do as a nurse if the patient is in the hospital? Well, check their INR and make sure it's not too high. Check their PT, make sure it's not too high. And check their PTT and make sure it's not too high. And check their platelets. If their platelet is less than 150,000, so 150K, well, that's thrombocytopenia. They're going to bleed. So these are pre-procedure precautions. And you can see I can put them in this form, whether it's the Next Gen questions or the current NCLEX questions. They can be SATA questions, or the Next Gen, it can be multiple SATA. Basically, you can have to select. You got to know as you educate the patient or as you prepare for the procedure, and then they can have multiple questions in the Next Gen. So this is the same thing. If you know it, no matter how they set the question, how they present it, where you have to select a box or anything like that, it's the same thing. So pre-procedure, you tell them all these things. And what do they do with the procedure? Well, the liver is on the right upper quadrant. So they lay on their back, and then so they will lay on their back, and the biopsy, and their hand will be above their head, and they do the biopsy and at the right upper quadrant, and then they take whatever biopsy. Usually they're looking for the tissue to make diagnosis. So they go here, take a little bit of the liver tissue, and then they done. So that's the pre-procedure. Of course, this is not an emergency procedure. So what do you think if patient is not undergoing elective procedure and there's no emergency, patient can consent? Well, you need to have an informed consent. Of course, you don't obtain the consent. You make sure that the consent is obtained by the provider. But you make sure there is a consent and you sign. What I mean is you witness the consent. Patient sign the consent after being canceled by the doctor, and then you witness the consent. So these are the things you need pre-procedure. And after they remove the procedure, then what do you do? So post-procedure, what are the things you need to know? We're dealing with a vascular organ. And what we did pre-procedure is to prevent them from bleeding post-procedure. Therefore, at the end of the procedure, what do you look for? Well, post-op, you should be looking for things that will cause the patient to bleed. Signs of bleeding. So you're looking for signs of bleeding. So monitor the patient for bleeding or hemorrhage. And then how do you do that? Well, there's a way you have to check their vitals. If you check my B sharp, not expected, prioritization, well, shock. You got to prevent shock. And shock will present with what? Increase in heart rate, decrease in blood pressure, decrease in urine output, and a acute change in mental status. So all these things, you have to be watching for bleeding. And so in order to know this, you got to check, you assess their vitals. So assess their vitals. Vitals. This is not the patient that you check vitals every 4 hours. What you do is the first 1 hour, you check their vitals 15 minutes. So you end up checking a Q 15 minutes the first 1 hour. So you check it 4 times. The second hour, you check it for 30 minutes. So Q30, the next 2 hours. Then after that, you check it every 4 hours. So the first hour, every 15 minutes. So you check it 4 times here. The second hour, you check it every 30 minutes. So you check it twice here. And then every 4 hours. The key thing is, to prevent bleeding. We stick the liver, we put a needle through the liver, and we want to prevent hemorrhage. So your board examiner, initially when you do the procedure, you let them lay on their back. But after the procedure, the examiner wants you to know how to prevent bleeding. So they will ask you questions. You need to know that now you need to put pressure on the liver because the liver is inside, you can't put pressure on it. What you can do is you can press the liver on the rib cage. If you put your hand on your right side, you can see the ribs go all the way down where the diaphragm is. So the rib can act as a tamponade to put pressure on it. So you put this patient on where you did the puncture. So patient should be placed on the right side. So they lay, because the liver is on the right, so they lay on the right side. Or they will say on the affected side, or where you did the procedure. So place them there on the affected side. What is going to happen? They have to lay on that side for 4 hours. So lay on the affected side for how long? 4 hours. They have to lay flat. No, sorry. They have to still lay on the bed. So lie in the bed. So you can say bed rest for at least 12 hours. So they will be in bed for 12 hours, but 4 of those hours they lay on the affected side. So they lay on the affected side for 4 hours. Then after that, they can stay on their back for the next 8 hours to a total of 12 hours to prevent bleeding. So at least 12 hours bed rest. And so you expect that this will be like a certain form of question. And then because we're looking for hemorrhage, when they give you a prioritization question, if somebody have a liver biopsy and you walk in and they lay on their back, you know that this is absolutely wrong. This is wrong. Patient is going to be bleeding. So this is the one they can ask you intervention. I need to intervene for this patient who had liver biopsy, is laying on his back. I got to intervene right away. So that is wrong. They have to lay on the affected side. Somebody have a liver biopsy, his blood pressure is 90 or 80. I need to intervene, call the doctor. That's a priority. Somebody with liver biopsy, his heart rate is 120. I need to call the doctor. Somebody with liver biopsy, his urine output is 30 for the last 4 hours. I need to call the doctor. Somebody with liver biopsy with change in mental status, I need to call the doctor. All of them is in B sharp. It's a shock phenomenon. Somebody with liver biopsy with ecchymosis in the belly button umbilicus, I need to call the doctor. Somebody with liver biopsy with Gray Turner syndrome, no, Gray Turner sign, that means bleeding in the frank area, retroperitoneal bleeding, I need to call the doctor. You see what I'm doing? I'm giving you signs and symptoms, prioritization, patient that you need to call the doctor right away. These are the way they're going to present those questions. So liver biopsy, with all those things, I need to see them first. Liver biopsy, laying you on the back, I need to intervene. These are the preoperative things you need to do and before the procedure. So that's all you need to know for liver biopsy. It's very important and it's straightforward. So we move on to the next procedure. Kidney is almost the same as the liver, but the kidney is located at the back, on your back. Okay, there's 2 of them on your back, and it's located in the retroperitoneum. So if this is your back, one kidney sits here like that. The other kidney sits here like that. And then it goes down into your bladder. This is the urethra, and it goes down into your bladder. And these take the urine. So these are your back. The kidney is also a vascular organ. It receives a lot of blood so that it can filter the blood. It filters the blood. That's how you make urine, all the chemicals. So you send approximately 25% of your blood to your kidney so that your kidney can filter it. That's how much blood you receive at a time, so that it can filter it and take all the chemicals from it and make urine and return the rest back to the heart. A vascular organ, and you're going to puncture it. Well, if you puncture, it's going to bleed. So pre-procedure, the same thing. Avoid things that will cause hemorrhage after the procedure. So they need to stop NSAID. If they take aspirin, they need to stop it at least 7 days. If they take Coumadin, they need to stop it for 5 days. If they take any of the factor 10 antagonists, inhibitors, they need to stop it based on the half-life. You need to check their PTT and INR, otherwise they will bleed. You have to check their platelets. All this I'm writing is related to bleeding. You see how you can get, not just memorizing it, but knowing that, oh, I'm worried about bleeding. I want to prevent bleeding. These are the things you do. If platelet is less than 150,000, well, then you got to stop it. There's something specific about the kidney that you need to know. Hypertension. If their blood pressure is really uncontrolled, when your blood pressure is uncontrolled, there's a lot of pressure in the kidney, and that will cause more bleeding if you puncture it. So uncontrolled hypertension is no. You got to control this is a contraindicated. So you got to make sure their blood pressure is in the normal range before you do a liver biopsy. You should avoid it. So same thing, select or apply or application question. So, and these are the things you tell them. Now, after the procedure, well, we want to prevent what? Hemorrhage, the same thing. If you puncture a vascular organ, you need to prevent hemorrhage. And therefore, you should monitor them like you monitor the liver biopsy patient. The first hour, you do 15 times 4. Second hour, Q 30 minutes times 2 for the net, then every 4 hours. Those are their vitals. So you're monitoring their vitals. You monitor their vitals. And then you have to know where to put them. The same thing, you want to put pressure on the organ that you cannot feel, but it's inside you. So the kidney is on your back. When they're doing kidney biopsy, they place them in the prone position. Prone position is when they do the biopsy. After the procedure to put pressure on the kidney, they need to be what? Supine. So they lay on the kidney in the supine position for at least 6 hours so that can prevent bleeding. And then after during your monitoring, when you're checking the monitoring every 15 minutes for times 4 in an hour, every 30 minutes to the next 2 hours, what you actually looking for is looking for their blood pressure. Make sure it's not too low. Make sure their heart rate is not too high. Make sure their urine output is not too low. Make sure they don't have acute mental status change, because the kidney is also is mostly located in the retroperitoneum compared to the kidney, compared to the liver. Look for periumbilical ecchymosis, which is Cullen sign. Cullen sign. That is retroperitoneal hemorrhage. That means they bleeding. Look for gray tenor sign. That means they have flank ecchymosis. That means they bleeding. All this is the S of the B sharp. They are in shock, and these patients need to be seen as priority. So if they give you a patient, it's a kidney biopsy patient, is laying in the prone position after the procedure, well, it's a priority because it's going to bleed. Laying on their side is a priority. They're going to bleed. They have to be what? Supine. A kidney biopsy patient with urine output less than 30 cc, well, is bleeding. That is shock. Change in mental status is bleeding. That is shock. His blood pressure is low. Is bleeding. That is shock. His heart rate is high. Is bleeding. That is shock. He has ecchymosis at the belly button. That is periumbilical ecchymosis. Is bleeding. That is shock. He has great Turner signs. Is bleeding. That is shock. And you can see how I'll put them together. And that is how they're going to ask you those questions, whether in the new generation questions or in the current SATA or intervention questions, education questions, all of them, or prescription by the doctor and the nurse intervening. Doctor said patients should lay prone after the procedure. You said no, need to lay on their back. So that is all you need to know about kidney biopsy. The next one is cardiac catheterization. And that is something they also they ask a lot, and it can ask you in different way. So in cardiac catheterization, okay, if this is you, your heart is here, and he has his vessels, okay. The aorta come here like that. I did not draw it well. It goes all the way and down and branches into the femoral vessels in the iliac, and then the femoral, you have the femoral vessels here coming down. So we can get into the heart, your heart, by puncturing here. So they'll puncture it with a needle. They put wires through it in your groin. So that's the femoral artery. Okay. They puncture the artery and they put a wire through it all the way going to the aorta, abdominal aorta, and then the ascending aorta into the heart. And they look into your coronary vessels. And this is done to make diagnosis of CAD, coronary artery disease, if you have thrombosis there, or if you have stenosis, that means the artery is blocked. That's why you may be having angina. So they do that to open the vessel. Probably sometimes they stent it. All this is done through the groin. There's no incision anywhere, just the groin incision. So they puncture, you have those puncture wounds. And so this is the procedure they do. You have to know that pre-procedure, because of the way it's done, you got to educate the patient. Okay, it's elective procedure, so they need another consent. They will use contrast. So most of the time they use iodine contrast. So you got to ask the patient whether they are allergic to iodine contrast or they have had contrast allergy. If they have had contrast allergy due to iodine, they can still have the procedure, but watch the question, the way they phrase it. This is if it's an emergency, they can pre-medicate them to lower the intensity of the reaction. They can give them steroids and antihistamine. So it depends on the way they phrase the answer choice. Okay. But most you have to check for contrast allergy. And if they're allergic to contrast, some procedure can go on, but you got to pre-medicate them with steroid and antihistamine. If they have shellfish allergy, it doesn't matter. Now, shellfish allergy, it's not a problem. They can get an iodine contrast. You have to educate them. When you inject contrast through the vein or the artery, you feel like flush feeling. So they can have flush feeling. They feel really hot when you get a CT scan. So you educate them. They can feel some warm feeling when the contrast is going into their body. That is okay. If they have diabetes, you have to find out if they're on metformin. So usually 24 to 48 hours, they have to hold the metformin. Kidney function is abnormal, I shouldn't do that. If you're allergic to contrast, I should pre-medicate them and make sure I have to check it. I should educate them, get a consent. And so this is what you do pre-procedure function. Now, like during the procedure, yeah, they go to your groin, injects the contrast and look at the pictures in your heart. They can put stents in it. After the procedure, so post-procedure, the same concept. I went through your vessel and I punctured it. And I did my procedure. Well, if you puncture a vessel, it's going to bleed. So we have to worry about hemorrhage. So you check for hemorrhage. This hemorrhage now is in the groin. We can feel it. So usually they have pressure dressing there. You do the same thing. You check their assex, their vitals. That's how you can initially see if they're bleeding. The same thing. Q 15 minutes, the first 1 hour, so times 4. Q 30 minutes, the second hour, then Q 4 hours later. This patient, you also position is very important. They lay flat and they don't move the extremities. The affected extremities need to be flat for 6 hours. Because we puncture a vessel, if you listen to my other lectures on cardiology, if you puncture a vessel, then you should check pulses. Otherwise, the vessel, they may have thrombosis of the vessel and their pulses will decrease. So these patient pulses is a priority. Check their pulses on the lower extremities after cardiac catheterization to make sure. We went into the groin. So what do you think you should do? That is the earliest place you will see hemorrhage. So you see hematoma in the groin. So check the groin for hematoma. And if you see bleeding there, don't put gauze on it. Put pressure, direct pressure, but just, so if this is the vessel, okay, I should use the red one. If this is the vessel and he's bleeding, I puncture here and he's bleeding all over here, well, where would I put my pressure? In your answer choice, look for just above where you did the puncture. So when you puncture here, no more blood coming down and this will clot. So you don't put pressure right where the puncture holds. You put it just above it, and that will ensure hemostasis and the clotting of that area. So you check the groin for hematoma. Because we went into the retroperitoneum, the aorta is behind everything. So it's in the retroperitoneal position. If they're bleeding, you should do the same thing. Look for Kerlin sign, periumbilical ecchymosis. That means there is hemorrhage. Look for gray Turner sign. That means ecchymosis on the flank, on the side. That means there is bleeding in the retroperitoneum. If they complain of back pain, that means they're bleeding at the retroperitoneum. And what do you think? B sharp, S shock. Their blood pressure goes down, they bleeding. Their heart rate goes up, they bleeding. Urine output go down, they bleeding. change in mental status, they bleeding. The same thing keep on repeating itself, the same thing. You see how everything is connected. So you should be looking for that. Then for cardiac catheterization, look for blue toe. That means they have thrombosed the vessel, there is ischemia. And so you should worry about it. Once again, somebody has cardiac cath and is not laying flat for 6 hours, you should intervene. It's a priority patient. His leg is not flat, it's priority patient. You should look for that. So those are the information you should know for cardiac cath and everything. They likely to ask you in your exams. And finally, lumbar puncture. Okay, so why do we do this? Lumbar puncture is basically they go into your spinal, not into the spinal cord itself, but the fluid surrounding the spinal cord. So if this is your vertebrate, okay, and the spinal cord is in front here. There is fluid around it. Okay, there's fluid all over here, inside here, that's around it. And usually we want a sample of a CSF so that we can analyze it, cerebrospinal fluid, so that we can analyze it and see if there's infection. So we want to get the fluid so that we can analyze it and see if there's infection. So we go through between the vertebrae and get the fluid, and take a little bit of it. I don't need to give you details, but basically we're taking a sample of this fluid, clear fluid, and usually we go between L3 and L4, basically lumbar 3 and lumbar 4, lumbar vertebrae, and go there and take a sample of the fluid and send it to the lab and then analyze it. So it's for diagnosis. Basically, some patients have meningitis or if they bleeding or anything like that. But mostly, if there's some kind of infection or diagnosis for neurological problem, we do that to make a diagnosis. So that is the point of that. So this is elective procedure. It's never an emergent. So most of the time, pre-procedure, this is pre. This is something they can ask you, select or apply. Patients still need a consent. This is very important. The head, spinal cord going to your head. It goes all the way, it's part of so this is your head. And this is all the fluid go into your head and around the brain, where the brain is, and spinal fluid, and you go into the center of it and it come down. Well, before you do any fluid removal of the CSF through a lumbar puncture, you got to make sure that one, there is no bleeding anywhere in the head, and two, patient does not have tumor, or three, yes, they don't have any mass, or their ICP is not already high. If you puncture here, the pressure, because basically the high ICP in the brain and the tumor or the whatever is there causing that pressure, if you puncture, you release that pressure, and what the brain is going to do is herniate down, herniation, and you kill the patient. So watch out. And before you do CSF lumbar puncture, before you do any lumbar puncture, you need to get a CT scan first. Number one, get a CT scan to make sure that there is no, once again, there is no brain lesion anywhere in the brain that will herniate without because of the change in pressure. So they get a CT scan. Okay. This patient is going to lay on their side. So lay on their side. Or sometimes they sit and bend forward. So sit up and bend forward. So there's two ways, depending on the doctor. So either they lay on their side in the fetal position like a baby, and so that their back will be retracted, bent, or they can bend, sit up and bend forward. So that's the position. They can empty their bladder so that they don't have to go, because they're going to lay flat for a couple of after the procedure, and they don't have to go during the procedure. So empty bladder. And the same team, we sticking, we're making a needle stick. Okay, you don't want to cause bleeding in that kind of procedure. So if they're on any medication that will cause bleeding, like NSAID, aspirin, Coumadin, factor 10 inhibitors, direct, like agatobans, you should let them stop. You should make sure their platelet is okay, is greater than 150,000. The same concept, so that they don't bleed. After the procedure, okay, post-procedure, the common symptoms for lumbar puncture is headache. So in prioritization, in my B shaft, not expected, if they tell you patient had a lumbar puncture, now has a headache, you don't need to see that patient. It's a common expected. This is an unexpected finding. So that's not a priority patient. Lumbar puncture with a headache is an expected finding. They need to lay supine on the biopsy side. So when you do the puncture at the back, they need to lay on it to put pressure there so that the CFS doesn't leak through the hole. So they have to lay on their back at the end of the procedure, or where you did the procedure, they have to lay and put pressure on it to lay on their back for 4 hours. Okay, you can raise up their head with up to like 30 degrees to help with the headache. So they can raise their head up to like 30 degrees, but the back has to be flat. Okay, their head can go up, but their back is still flat. Okay, you're looking for clear fluid. CSF is very clear, so you're looking for fluid leakage. So that's what you're watching for this. For this one, headache and leakage of CSF. If there is a CSF leakage, you give them fluid to replace the fluid that is lost. If that doesn't help, they will get what we call blood patch. So blood patch for treatment of CSF leakage after lumbar puncture. They get fluid. Fluid is mostly if they have headache. If they have headache, you give them fluid. If you see CSF leakage, you let them lay on it flat, give them fluid. If that doesn't help, the final answer is blood patch. So CSF leakage, let them lay flat, give them fluid. If it's still leaking, they need a blood patch to take care of it. Headache is a common problem. Before we finished, just want to tell you, I don't know if they can go into details, but I'll use this. CSF, when you take it, you send it to the lab for analysis. The reason why we do it most of the time is that there's a bacteria or viral infection, and this is what we mean by meningitis, basically. Okay, or other neurological problem. Okay, you don't need to know the normal values if they give you, but this is normal. Okay, I'll put normal here. I won't give you the normal values. In CSF, the color, okay, this is clear. If it's normal, it's clear. If it's bacteria, you know, you expect infection, so it's turbid or cloudy. So if they give you a question, they ask you, patient bacterial meningitis, what do you expect in CSF when it's going to be cloudy. If it's a viral infection, it will remain clear. The CSF has proteins in it, okay? Usually when it's a bacterial infection, proteins goes up. It's because of the inflammatory process. So protein goes up in the bacterial infection. In the viral, it can remain normal or it will go down. The other thing they will ask you is glucose. Those are the two things: color, protein, and glucose. Bacteria love glucose. So when it's a bacterial infection, bacteria chew all the glucose. So the glucose will decrease. Virus doesn't like it that much, so it will remain normal. If you do a gram stain to see if there is infection, this is going to be positive because it's a bacteria. Gram stain is looking for bacteria, so it will not see a virus, so it will be negative. And if you want to look for cell count in terms of infectious cell count, what do you think you're going to see in bacteria? Well, you see a lot of neutrophils. And now about viral. What is the common cells, that infectious cells that shows up when you have viral infection? Is lymphocytes. So I just put this there. I don't want to give you numbers. I don't think it matter. I don't think they will bother you, but they will give you, even if the next gen questions or current, they will tell you bacteria, the protein in the fluid has increased or the glucose has decreased or that. So if it's a bacterial infection, if you do a CSF, you will look turbid. There's more protein. There's decreased glucose, and the gram stain is positive, and the cells are usually neutrophils. If it's a viral meningitis, the CSF is clear. The protein may be normal or decreased. There may be normal glucose because they don't like it. And then the gram stain will be negative, and lymphocytes are normal. So this is all 4 key information that you need to know in terms of procedure: lumbar puncture, liver biopsy, kidney biopsy, and catheterization. Remember, lumbar kidney biopsy, renal biopsy, catheterization or cardiac catheterization, the key thing is hemorrhage. So everything is based on hemorrhage, and it's a B-sharp priority question, not expected. I hope you have a good day.